Okay, so the last category that we're going to talk about here is neck pain with headaches, cervicogenic headache. So, this category is in your neck pain clinical practice guideline. You can see the common symptoms, expected exam findings. We'll go into a bit more detail. And then remember, you have to stage them next to be able to match them up with the most evidence based interventions. And we'll go over those as well. So, neck pain with headaches, the common symptoms are a non continuous unilateral headache, and that headache is aggravated by cervical range of motion or sustained postures. The exam findings that you'll find are a positive cranial flexion rotation test, the headache reproduced with accessory testing, particularly of the upper cervical spine, impaired cervical range of motion, reduced upper cervical mobility, and then neck muscle strength, endurance, and coordination deficits. Be sure that when you have a patient with neck pain with headaches, that you monitor the frequency, the intensity, the duration of their headaches as a continual monitoring. So just don't forget to do how often, how intense, and then how long are each of those headaches lasting. Some of the mechanisms we think happen with how the cranium is involved in this neck pain is from a dysfunction in the upper cervical spine. Most likely, this will account for 14 to 18% of all headaches. Women are 4 times as likely to be affected as men. And really, this is a referred pain, so a convergence of afferent input from the cervical spine. There's also a possibility of direct irritation of the C2-3 nerve root. You can see C2 nerve root here in green, the C3 nerve root coming out here, but equating to this area, I believe. And then the trigeminal nerve, all 3 branches, we'll talk about that. So the referred pain pattern there is on the left of the various cervical spine levels. So you can see the frequency in which they refer. So like C0, 1, they're most likely going to have pain at the base of their skull or in the upper cervical spine, and then going to the eye or the front of the head. So that may be helpful in differentiating, but you see that most that are going to the cranium are really the upper cervical spine. And then over here on the right, so this is C1, 2, 2, 3, 3, 4, and they're just irritating the synovial, or using a block for the synovial joints, and so these are the areas of pain relief from those areas. So C1, 2 going to the top of the head, the base of the skull or upper cervical spine, and C2, 3 again going towards the front of the head. And there's a little bit of difference here between the interspinous and then the synovial joints. So we also have to consider some muscular contribution in cervical headache. So we have splenius capitis and cervicis here on the left, and you see those pain referral patterns, and then some spinalis capitis, the upper portion and the middle portion here on the right, inferior obliquus, and then rectus capitis posterior, major and minor, and then cervical multifidi, and that'll vary a lot based on which level it is. So some clinical tests to help differentiate cervicogenic headache from other types of headache. So Zito took 77 people with various types of headaches, so about a third with cervicogenic, about a third with migraine, and then 25 controls. The cervicogenic headache group had decreased cervical range of motion, particularly flexion extension, increased tenderness to palpation of the upper cervical spine, increased upper cervical muscular tone, and decreased mobility of those upper cervical joints. So from the International Headache Association, I think it's called, we have some criteria for cervicogenic headache, and this is signs and symptoms of neck involvement. So usually precipitation of head pain with neck movements or sustained postures, external pressure, so palpation of the upper cervical or occipital region, and then restriction of the range of motion in the neck. They confirm this with some diagnostic blocks, which we won't be able to do, but usually those headaches are unilateral without side shift, meaning the primary headache is on one side most of the time, and it doesn't kind of switch back and forth from left to right. The patients will describe the headache as moderate to severe, a non-throbbing, non-lancinating pain. Usually it will start in the neck and then kind of go to the head. It may vary in duration, but usually once a headache starts, it's fluctuating, so it gets better and worse, but it usually stays in one episode, meaning, they're not having a headache and it go away and headache and it go away. It's just a headache, and then it gets a little better and worse until it goes away. So we talked about decreased range of motion, particularly going to be C01, C12, C23, probably some hypomobility and or tenderness, some muscle inflexibility or trigger points, and we talked about those. And then a positive cervical flexion rotation test, and that's really looking for involvement of AA or C12, and then deep neck flexor weakness and or poor endurance of those deep neck flexors. So to help rule in, right, we need to take a thorough history, take a look at their range of motion. We need to do some accessory motion testing of the upper cervical spine, use some palpations and muscle function tests. We talk about what those particularly are later. And then some things you need to do to rule out. We need to do an upper extremity neurological exam. And we need to do upper motor neuron tests, and then we need to do a cranial nerve exam, and that one's mandatory, right? Because when symptoms are in the cranium, we need to do a cranial nerve exam. Sperling's test and upper cervical instability tests as a differential diagnosis. Some other differential diagnoses here are a trigeminal neuralgia. So essentially looking for this particular pattern of pain. And then intracranial pathology. So this is usually described as a sudden onset of severe headache with increasing intensity. They may wake the patient during the night or early morning. We need to rule out any signs of meningitis, so like a stiff neck or other systemic symptoms, weight loss, fever, malaise. Any focal neurological signs, so doing that cranial nerve exam. Different types of headaches, though. There is a tension type headache, so it's a dull pressure tightness, usually described as a band around the head. This can last pretty variable, 30 minutes to a week. The frequency can vary as well, and other common signs that accompany this are that they're tired, that there's a sensation of a circular band on the head that's kind of tightening down or tensioning on the head. Migraine, the location here doesn't really help you. 60% on one side, 40% of those reporting it being bilateral. It's though described as a throbbing headache and kind of varies in duration and frequency based on that person, but it is usually accompanied with other signs of nausea, vomiting, sensitivity to light or sound or smell. And so often we'll just try to find these triggers for those folks. But in looking at a table to help differentiate here, we'll need to look at the numbers here on which is actually the accurate numbers, because we said before that females were 4 times more likely to be than males, and I think that's more accurate than this table. It's a little outdated maybe. Age at onset, you see a little bit of difference there. The headache onset may start in the front of the head for migraine, and usually for cervicogenic it starts somewhere on the posterior cranium or the neck and then can travel to the front. And we talked about some of those other accompanying signs like nausea, sensitivity to light or sound. Cluster headaches are another type of headache. This is usually a really, really severe type of headache that's located over the eye and is pretty severe. They don't usually last that long, but they're really intense and they may come in clusters during the day. So there's some other signs and symptoms associated with that, like some nasal congestions or runny nose, redness of the eye. They are usually pretty agitated because the pain is pretty severe. So, okay, looking at our exam, right? We need to be testing specific vertebral segments, especially the upper cervical, and then our cervical flexion rotation test. So how do we do that? So the flexion rotation test is really a C1-2 assessment. So the patient's in supine and you flex them all the way up. And when you think you flexed them far enough, you're probably going to flex them just a little bit more. We'll talk about that in lab. And then you rotate, maintaining that flexion pressure. This is actually really, really hard to measure with one person. There's a 32-degree cutoff for cervicogenic headache. That's the study you see below with the sensitivity and specificity. The minimal detectable change being 7 degrees, and normal is 45 degrees. So you see the flexion rotation test there in the two pictures on the left. And then this picture here on the right is more of a, what we're terming here, a joint lock versus myofascial lock. Don't really get too hung up on that. Just know that it's two ways to kind of take the lower cervical spine out of that and really just look at upper cervical rotation, which really only comes from C1-2 because C0-1 doesn't do that. So you're taking them into maximal side bending and then maintaining that side bending and assessing rotation. So the flexion rotation test is going to be a bit more valuable to you from a diagnostic standpoint, but there may be reasons that the patient's just not comfortable with that. Okay, so flexion rotation test, maintain all of that cervical flexion, and then go into rotation. Okay, and then taking a look at C0-1, you're going to rotate the patient's head just a little bit to the right or left, and then take them into some upper cervical nodding. You can do that holding on the zygomatic arches. Not as comfortable that way, but you can use the front of your shoulder to also complete that upper cervical nodding, almost a push down towards the table. Deep neck flexor endurance test. This actually is not a picture of that, but it kind of starts in this position. So the patient's lying on the table, usually don't have a pillow under their head at all, but maybe a folded up towel of about an inch or so, or nothing under there. So you have the patient hold a chin tuck. You can help them assume that position. And then you have them just lift off of your fingers. So the hair is still touching your fingers, but they're just barely off of that. And how long can they maintain that cervical flexion? In the original test, they had the patient fully chin tuck and put a Sharpie line on the chin fold, the neck fold, the double chin in the front, and then if you could see a break in that line, then that would indicate that they failed the test. So normal for this is 38 seconds. Those with neck pain are somewhere less than 20 seconds. The craniocervical flexion test, so the CCFT, and remember the other is the CFT, cervical flexion flexion rotation test, CFRT. So just make sure you differentiate those. This is where we place that cuff, the pressure cuff behind the neck. We inflate that to 20 millimeters just so that it supports the natural curve of the neck, and have the patient chin tuck to just 2 millimeters of mercury there. So that's very, very slight, and hold about 10 seconds. And then if they're able to do that, they go back to 20. And then they reset and go to 24, and so on incrementally every 2 until they get to 28 to 30, and they're able to hold that for 10 seconds. Okay. So if they're not able to get to that 28 to 30, then we would say that there's an impairment there. We can easily turn this into an exercise. We're not on to treatment yet, but they can do various drills like go up to 24 and come back down, go to 26, go back down to 22, because this is much more of a motor control exercise. It's likely that most people are able to do that motion, but are they able to do it in a manner where they're really controlled? So you can call out targets and have them train that. Really just training proprioception here, right? Okay, so a hallmark treatment for those with cervicogenic headache is a C1-2 self-sustained natural apophyseal glide, which I won't say ever again. It's a snag, a C1-2 snag. So this study had 32 patients. The inclusion criteria on the next slide. Randomized to either intervention group or to placebo group. The inclusion criteria here, they diagnosed them with cervicogenic headache. They had to have a positive flexion rotation test of greater than 10 degrees. And remember that is implicating AA. So it may not be that everyone, unlike what the clinical practice guideline kind of suggests, that everyone should receive a C1-2 snag, but definitely those that have a positive flexion rotation test, it would be wise of us to include an AA intervention when we've diagnosed them with an AA problem. So some exclusion criteria here: if the examiner determined that the headache wasn't from the cervical spine, if they'd had some previous treatment, and then kind of normal red flag type of issues. So the characteristics of the people included into this study, nothing really kind of stands out there. And then the intervention that they gave the patient to do 2 times daily for 12 months was a C1-2 self-snag with rotation towards their limited side. So this patient had a limitation in right rotation with their flexion rotation test. And so you essentially cross your arms, one arm comes down, and then the other takes you provides that overpressure with the strap that's coming over C1 into the limited range. Okay, this was instructed to be pain-free, so no other symptoms other than stretch should be provoked. The control group just did a sustained forward pressure at C1, so instructed to find C1 and then provide some sustained pressure just so that there's some equality between groups. So changes in the flexion rotation test you see there on the left. Obviously there's a greater change in that for those in the snag group. Remember that they started about 24 degrees and gaining somewhere around 15 degrees. So they're getting pretty close to normal, most of them. And then this is an outcome measure, the headache index, and you can see how much that changes over the year that they're instructed to do their exercise. Would love to know if we need to tell people to do that twice a day for a year or for the rest of their life, or is there something less that we could be able to give them that's not quite so strenuous or at least tedious for that amount of time. So Jewel took many patients. I'm not sure how many patients. So they had 4 groups of those with cervicogenic headache. So you see the inclusion criteria at the top. They were randomized to either receive manipulation, but that's mobilization manipulation as indicated as the therapist chose, or exercise. So they were doing some deep neck flexor exercise, scapulothoracic stuff, isometric neck exercises, or a control group, or a combined group, so manual therapy and exercise. And so here you see the change scores. They were treated over 6 weeks. So the baseline to 6 week outcome, you can see the control group here at the top, and the rest of the groups are down here, pretty similar in their change in pain scores. Again, we see for frequency of headache, we see the control group here at the top, and the other groups kind of down here clustering together for frequency of headache. And then really for duration of headache, you see control group, exercise group, manual therapy group, and then that combined group really decreasing the duration in hours of the headache. Okay, this study looked at those with cervical headache, and this was very similar to the mechanical neck pain study that was done. They did an upper cervical and an upper thoracic manipulation versus the other group that got upper cervical and upper thoracic mobilizations. They did a 3-month follow-up, found manipulation to be superior to mobilization for headache intensity and duration. And this is the same group that did that other study, and there were some pretty significant effect sizes there as well. And then Fernandez de las Peñas treats quite a lot of conditions, actually. So just had a kind of a master class article for clinical reasoning for manual therapy of cervicogenic headache, which we've already talked about really, but the tension headache may be helpful to you. And really they recommend that you try to inactivate any trigger points that may be there. The suggestion is to check the traps, SCM, temporalis, suboccipitals, extraocular muscles, and then maybe do some cervical MOBs and manips as you find in your exam, and then some deep neck flexor control work, motor control, and that realize that central sensitization is pretty likely in those with tension type of headaches. So maybe using some of the strategies that we've used for central sensitized patients already in the course.